Hello and welcome. We are super excited. Today we are talking, this is our third session, batch number 6, and we'll be talking about the basics of research. This is one of our high value lectures, not because I'm giving it, because it sets the basics for many of you guys if you have not been familiarized with the research as well. Overview, we will go back to our program at glance. We'll talk about a few slides, several slides on hypothesis, several slides on data type, study types, and then there may be a question and answer session, and then to-do your list for this week for those who have been joining us for the last few weeks. We are focusing on still in the first session of the week. This is where we are. This lecture we kind of revise it because we spent time a little bit on talking research idea discussion, and Dr. Fazal gave an extra talk, extra lecture. Today we are on week 3, week 4 actually. So we are giving this lecture and finalizing our research ideas as well. So we are on time and we like to keep it that way. What is hypothesis? We in the first lecture, those who have attended and watched it, we give an example that how you can put your research thought into a research idea and a research hypothesis. This is nothing but a specific version of research question that summarizes these 3 important elements of any research question. It talks about your study population, which sample you are looking into, what is your predictor variable, and what is your outcome variable. And then which provides the basics for statistical significance. And so the first thing before you do any big research project and all, if you can train yourself through these lectures and exercising to come up with a good hypothesis, it doesn't have to be fancy, but your hypothesis, if it's taking care of these parts, the main elements of what the study population you're looking into, what your predictor or exposure variable is, and what is your outcome variable is. It only applies to those who will be doing clinical research. Some of you will be talking about either review-based articles, systematic reviews on those things as well. It may or may not apply. You don't have to have a hypothesis, but 90% of the work, except a couple of you guys, most of you will follow this pattern of having a hypothesis there. What is the types of hypothesis? There are 2, simple or complex. Simple, I gave this an example, is based on if you have one predictor variable and one outcome. Example, if I come up with saying sedentary lifestyle is associated with increased risk of proteinuria among diabetes patient, or I can change it. I can say sedentary lifestyle is associated with increased risk of weight gain among the cohort, GRRSP cohort of batch 6. It could be as simple as hypothesis. I have one predictor or exposure variable, sedentary lifestyle, and I have an outcome here is in proteinuria. And if I took you guys as in a batch example, GRRSP batch number 6, that is also the same cohort. Complex hypothesis, if you have more than one predictor or exposure variable or outcome variable, it becomes a complex hypothesis. We did talk about it in the first or second session, where we talked that either you can have sedentary lifestyle and alcohol consumption are associated with increased proteinuria, or you can just say sedentary lifestyle is associated with increased risk of proteinuria and acute kidney injury in patient diabetes. It doesn't matter. You can have more than one exposure and more than one outcome. That still makes it complex hypothesis. But at your stage, my humble request with you is to keep your hypothesis simple. Keep that doing this intervention causes less risk in cybersecurity, or having this particular thing would increase the chances of crisis management, or whatever it is. Keep your hypothesis simple: one exposure out variable, one outcome variable, and it'll become very, very important as you go through. There are null and alternate hypothesis. The goal is that there is anytime as a scientist or medical scientist, when you're talking about, you're always thinking of null hypothesis. There's no association between predictor and outcome variables. That's it. That's your null, zero, no association. Then what you're trying to do is you're trying to reject this null hypothesis. So you're always trying to work towards an alternate hypothesis, the exact opposite of this null hypothesis. What we are saying in alternatives, there's an association between predictor. This example I gave it in last slide was sedentary lifestyle and proteinuria. So you're saying my alternate hypothesis is that there's association between this predictor variable, smoking, and lung cancer. That's your by default. That's what you're trying to prove. You're trying to reject the null hypothesis. There are 2 things, like you can have one-sided and two-sided. Two-sided you have it, then you're not committing to a specific direction of the issue. You have commitment phobia. You are saying it that I don't know which is better. If you're looking for drug A versus drug B, you're just saying that one of the drug is better. Then it's your two-sided hypothesis. but you're committing and saying drug A is better than drug B in protective mortality. Now you're calling it as a one-sided hypothesis. I'm a huge fan of one-sided. So then you know from the previous literature and your clinical experience, you can actually uh, coming in with an idea that, oh my gosh, giving this particular medication or giving this intervention is going to improve the quality of care, the rural care, the whatever you're doing is sepsis patient, whatnot. So you already have an alternate hypothesis in mind. Thinking of null clarify your minds, but you're always looking at an alternate hypothesis. Another thing is you don't write alternate, you just say my hypothesis is. So I would like you guys to think null hypothesis in the head and write alternate hypothesis as simple my hypothesis is, or we hypothesize that. That's it. And if possible, do it as a one-sided, means committing to saying this is going to be increase or decrease. Don't say just has an effect. Just don't leave it at two-sided, because then either reviewers will think that you don't know what you're doing or you're not expecting it. I'll give an example here very briefly. If my research question is whether there is a difference in the efficacy of medication A, salbutamol, medication B, ipratropium bromide, for treatment of asthma is my patient population. PICO question is also the patient population, comparative group, intervention group, comparison group, and outcome. If I say my null hypothesis, I'm going to say there's no difference between the efficacy of any of these drugs in treatment of asthma. My alternate hypothesis, I can say there is a difference, and I'm not committing to which is better, between salbutamol and ipratropium treatment of asthma. This is two-sided. If I say drug A, salbutamol is better than ipratropium bromide, or I say ipratropium bromide is better than salbutamol, then I'm committing it on one side, and I like you guys to be that way as well. So you are a one-sided hypothesis. Sometimes it's a necessity to have it two-sided because you don't know and there's no good literature, but most of the time you can actually commit to one side, and I'll suggest you to see if you think of it. Okay. As I mentioned, is like, so it's not ready to most of these cases are usually two possibilities. Two-side is conservative. If you're worried about reviewers dinging you on that, just go with the two-sided and saying, there is an effect, we don't know which one, and that should be fine. Okay, these are my few slides on hypothesis, null alternate, what hypothesis is, simple and complex, and single-sided and two-sided as well. So this kind of sets a tone for when you write these questions. Now, the second topic for today is types of variables. There are tons of different types, but this came out. If you think from medical research standpoint, patient data, clinical trials, research databases, using your primary healthcare data, using your hospital data and things like that, or publicly available databases, which we just publish in CHEST as an oral presentation. If I divide them into two major categories, numeric and categorical. The numeric and categorical are further divided into two, continuous and discrete, and categorical is into ordinal and nominal. And pay very close attention. You don't have to memorize this, but at least if you keep your things clear, numeric, there is a numerical value. Continuous is going to be your height, weight, length of stay, time. Those are continuous variables. Nominal, where you have yes, no, just putting into category of alive and dead, married, unmarried, male, female, something like that. Ordinal, when there is an order to it, in a sense. So these three, especially continuous and nominal, that will make up 90% of your research databases. You don't have to worry about anything else. 5, 6, 7% you will be using ordinal at times, especially Likert scale and all. And I'm going to go a little bit in detail. Discrete, you'll never hear me talking about it because discrete is usually used in public health places. I'll never publish a discrete data because it's not pertinent to what we do in this regard. So let's take on categorical variable to give you an example. These are unordered categories: blood group A, B, AB, different eye colors. There's no order. These are there, A, B, A, B. Usually it should be A, B, C, D, E. Then it becomes an ordinal value, but blood groups are A, B, and O. Same thing. Different states of US or India or any other country for that matter. Different hair color. There's no category. You can have brunette, red. I don't know. What do you call it, not purple, anything else, but I don't think any categories are there for that matter. And then gender, male, female, in a sense, and now you can add few things as well, intersex, and then transgender and so on and so forth. There's no category, so this is the numerical value you're using. Ordinal values, there's some order. Many of you either do Likert scale research questions, or satisfaction surveys among patients or anything, you'll come up with those things as well. We have used some of these things in our previous surveys with in an Indian National ICU Need Assessment Survey, Global ICU Need Assessment Survey, and Vishwas, the violence study of healthcare workers and system. We have used ordinal skill sets as well. And that there's an order 0, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, where they're giving it. It's not continuous. They are limited, a 3 or 5 or 7 or 9-point scales as well. Or there is an order for, I agree, disagree, strongly agree, and so on and so forth as well. 5 or 7% time in survey questions, or sometimes you have ordinal values in your database, you'll be using it. The rank 1, 2, 3, 2 also in this regard. I don't think so we need to go into too much detail as well, but in categorical variable, nominal, board, ordinal, these are qualitative data in a sense more than quantitative. They'll count it. Even though for analysis purpose, we'll be using them in quantitative. They give you a little bit information, some weak statistics and so on and so forth. You list them as count and proportion. Out of 135 male, 65 female, 35 in bracket, 35% male. That is the way. And this is going to be very important because you'll be looking at these things in tables, and I'll tell you, oh, this is the categorical, this is continuous data or nominal data. And that will help you write your method section that will be reporting our nominal variables as number and percentages. So anything what you learned today, it will help you in analysis, it'll help you in method section and so on and so forth. And proportions and median, same thing, you'll do it. And I'll talk about like how mean medians will be used later on as well. Now the other side, numeric value, where continuous and discrete. Let's take the continuous part of it. In practicality, in theory, it could be infinite numbers. Height could be anything, weight could be anything, time could be anything, length of stay could be anything. But in practical values, they are limited values. You can't have people a length of stay for 3,000 days or 6,000 days. It's not possible. You can't have people 9 feet tall. Those are all myth. But there's in theory, it could be anything. So any continuous value of weight, don't even let me start on weight in a sense, keep increasing every week. The height, weight, time, length of stay, length of mechanical ventilation, length of ICU stay, and all those things are a continuous variable. You'll be using it heavily in your research, both nominal and continuous. 95% time you'll be using this value as well. Discrete, these are limited number of value. And I'll give you an example that why it doesn't make sense in our field when we do it. So number of cars sold per month. Number of houses per city block in America, they use pretty, and number of fishes caught during each fishing trip. So these are values which you're using it in public health emergencies. How many patients per 100,000 per patients, and so on and so forth as well. You will never see me in any of my publications. I've used discrete values ever in last 700 papers we have submitted, published in last 17 years as well. But just good to know that sometime in public health areas or something, we ask you guys, hey, can you normalize it and say, if you have 3 million people and then the list is 235, can you divide them and saying what is per 100,000? That's why you're using a discrete value in this regard. How many per 100,000, how many per month people got sick and things like that as well. Otherwise, don't talk to me about it. I'll never mention this to you at all. I just want to introduce, we are doing really well on time. I'll be able to finish, I think, the 30 slides. Just these terms I would like to introduce and see how it could be confusing. So you've heard me talking about the predictor and outcome variable. Predictor, it's a variable that causes or predicts the outcome. Outcome, which is the result of the predictor. Okay, it's a self-fulfilling prophecy. Sometimes we use predictor as exposure, outcome as an outcome, so it's cause and effect. Predictor could be a cause and outcome is being effect. So if you hear me saying cause and effect relationship, predictor and outcome, exposure and outcome, they mean the exact same thing. Cause and effect caveat is it's only applicable to clinical trial where actually you can establish a cause and effect. Otherwise, mostly you are even calling it predictor or cause and effect. You're only saying it there's an association, because though the study designs are weak, we cannot establish a cause and effect mechanism through retrospective, prospective cohort studies and case control studies. But we use those terms to make a sense, make the point out of it. I'll give you a confusing example, and you should think about it. That could be one of the big things you can take out from today's lecture. Is if I look at examples of two variables, watching TV on obesity. In this example, if I say my research hypothesis is watching TV causes weight gain or obesity in people compared to the people who are not watching TV. Okay, then what I'm saying is watching TV is my cause and effect is obesity. Watching TV is a predictor, and effect is outcome is obesity. But I can reverse it too. I can say the obese people are likely to watch TV more than compared to going for bowling, going for walking, running, and all those things as well. Then, based on how you ask the question changes that, oh, obesity is caused, there is association of higher TV amount watching in people who are obese compared to people who are not obese, because of the inability to go out or whatnot, and they find friends like that, popcorn and soda and all those things. I have done all that. I become couch potato in the last few years. So, but the question is different, that if your research hypothesis is different, the variables are different, then what you're looking for first, if my first hypothesis is watching TV, then what I'm doing is I'm looking how many hours people are watching TV and then see how much weight they gain. Then I'm answering my first hypothesis. If I say obesity can cause watching more TV compared to less, then I start with the people's BMI first, divide them in two groups and see how much TV they watch. So this is so easy to think, because it's clear for us watching TV and obesity, but in real life, when you're looking at the patient data, it's not clear what is outcome and what is exposure. So you have to be very, very conscious about the fact, understanding what comes first, that becomes your cause, and what comes later becomes your effect. Effect can never come before cause, otherwise not an effect at all. Okay, and we'll go through these things, will come during discussions when you present it, and I'll bring up these points to make a point at the time as well. So and then there confounders, we'll go into that things which can affect both of them. They're not in direct line of association, but then you use them in a confounder and you later on adjust for them in logistic regression models and other things as well. We'll be not teaching the logistic regression models to you as well, but we'll be bringing it up. We'll study the things, and then the concept should be clear to you, at least if you can't do the regression models during these 6 months. It's hard to teach a research class in 6 months, but at least you will know the basics about it. Okay, now I'm jumping into last 6-7 minutes, different types of studies. We did talk about observational study, which is simple. You're just drawing observation from a sample of patient population where the variables are not in your control. It could be descriptive or analytical. Descriptive is you're just describing what is the presence of predictor and outcome. You're not creating any analysis or association between them. And analytical study design, you're characterizing an association between predictor and outcome variables, and they are as case control, cohort design, and or clinical trial, which is also analytical study design as well. Case control, very important. Sorry, cross-sectional, very important. All survey-based studies, what you're doing is they are cross-sectional, where you look at the measurement at one occasion, look at the people, you ask those questions, you never follow it to them. That's your cross-sectional design. Cohort design, you follow them over the period. You ask a question today, you're asking them to come back again, have the blood pressure 6 months from now, or repeating the question, then it becomes a cohort study design that you're following that cohort in a sense. So the difference is it's a one-time data collection, data measurement compared to multiple time in cohort study design. Example, if you measure body weight and blood pressure when patient comes to an outpatient setting and you're creating an association, it's a cross-sectional design. If you're doing this measurement over years, multiple times, then it becomes a cohort study design. Very simple, but understanding the concept helps you out. Cross-sectional, what you're doing is you're taking a snapshot of the population at one given time frame. It gives you that particular thing. So see, if I take a cutout in the between, it gives me that situation for this particular fruit at the time. That's a cross section, and then the corners, the upper end and lower end could be very different than this cross sectional. That is the weakness, that you may not be able to get the whole population. You're just getting the middle part, and you are getting this in between, and that's it. So it's good, it's inexpensive, but it is limitation that you're missing the rest of the population, which may look very different from this patient population. Both of these things are being done at the same time, that you look at the disease and exposure. I had this slide in the past, but the one thing I want you to get out from this is that you're just describing both variables present at the same time, and then talking about that, hey, we could get the exposure and outcome at the same time. You have to be very clear what is your exposure, what is your outcome. Cohort study design is that we've talked about it. You follow them over time. You are looking for predictor variable. You have your outcome variable. You are measuring it. Prospectively, you can do it that you look at the exposure now and follow them in future, and in prospectively to look for the outcome. That's your prospective cohort study design. Retrospective, there are many benefits for it. that outcomes has not happened before. So this is going to happen. You have a good chance to collect it as well, but there are different things can happen in between which can affect your outcome. You can measure them and make it a very strong opportunity as well, but it's going to take a lot of time and energy, and there might be some dropouts as well. So it makes it an expensive part. You have to wait for that long, and then you have to have people to go out and ask questions and all those things as well. There's some benefits, but there's some downside as well. Retrospective design, what you do is you go back in time. You have the data now, you want to go back, outcomes now, you want to go back and see who had the exposure at the time. And usually you do it through electronic medical record and baseline follow-up. It's very less costly and less time consuming. But then you have some issues that, anything which has happened in the past, which you could not measure through EMR, you're going to lose it out, and that becomes your known or unknown confounders as well. So the cohort design is same. You follow them. Retrospective, prospective in future, retrospective in the past, but your principles of cause and effect say the same. Cause has to come before the effect, exposure has to come before the outcome. That principle doesn't change. Case control design is a little bit different. What you're doing is you're looking at the patients with their outcome first. You're finding a comparative group which doesn't have the outcome, people with the cancer, without the cancer, and you go back in time and see who got the exposure. Okay, it's like a retrospective cohort study, but you're not starting with the exposure and looking at the outcome. You're starting with the outcomes, finding a comparative group, and then looking at the outcome for both sides. This is the both. It works backwards. It's still the sequence of things from effect to cause to effect doesn't change. Cause has to happen first, effect to have to happen later. How you look at the data in future, past, and where you start with, that defines your case control cohort study design for that. It is inexpensive, one thing, and this is one of your USMLE questions, folks. Step one and step two both. This is inexpensive, but for rare diseases, this is the best design for case control study. These are always retrospective in design, and they are very good for generating hypotheses. So these three questions have been asked in UWorld and USMLE by different mechanisms. That what is the strength, and for rare, if they give you something rare disease, then you know that you're working with case control study design as well. Okay, I'm at 1 minute and I was able to finish all 30. So this is my 28th or 29th slide. Remember the PICO concept. We will always talk in that language. What is your patient population? If it is patient-related topics, research, intervention, exposure, control, comparison group, and outcomes, so on and so forth. And this figure, which I've showed it to you in the first or second lecture, it gives you a comprehensive review of how the design group work. Your clinical trial, prospective design, retrospective cohort design. You're still starting the risk factors and outcome. Case control, start with the outcome, find the non-outcome, go back in time, but it's still your risk factors are happening before. So risk factors have to happen before outcome. That is universally, you can't change that fact. Cross-section, you're looking both the things in the present time compared to looking into future and past. This, we have seen it. If you're not sure, this slide is available. You watch in the video that how to decide what your study type is, and we can add a few things to that too. But I'll tell you that as before we end the session, our session number 3, to do your list is, if you're not watched the video, there are a few more videos we're going to be adding to your watch list. Please do watch them. There are more than these videos you can watch. We have roughly 100 videos, and out of them, 25 or 30 are very, very important to you as well. If you have not created your social media profiles on LinkedIn and Twitter, or not send us your handles yet, or we have not tagged you at least once in on those things, please do so. You're missing out on some shout outs as well. Next week, when we meet on Sunday, we would like to have, if not today, a half page to 1 page of your finalization idea. Email it to Faisal and I, and then we will let you know how to add it to Google Drive. I'll stop the recording right now, and then we'll go from a question and answers and see if we can move forward some of the discussions. All right, watch the videos and like it.